Good morning. A very warm welcome to a cold Birmingham. It is my privilege and pleasure to stand here welcoming all delegates to the 28th Annual Scientific Meeting of the Difficult Aware Society on behalf of the local organizing committee and also on behalf of the Difficult Aware Society. Can I request Dr. Imran Ahmed to come on the stage with me, please? Yeah, he's here. Thank you. So, we started this journey more than 5 years back in 2018. Yes, 5 years, it's a long time. In May 2018, we put a bid to run the 2020 annual conference of DAS, which was the Silver Jubilee meeting. And we were unsuccessful. But by the turn of events, the successful venue couldn't go ahead because of some issues with the venue. And we were asked if we could do this instead. And we happily agreed. And then, you know what happened in 2020, the pandemic. So we had to postpone it to 2021. Pandemic didn't go, so we had to postpone again. You know, you can imagine how much stress the organizing committee and DAS have been going through during those periods, because in addition to the human effort, there are lots of money involved when you postpone a conference in a venue like this. Anyway, after 5 years and 3 DAS presidents, we are here. We are proud to have created an excellent scientific program with eminent speakers coming from all over the world. And we got a good attendance. I think it's one of the most well-attended DAS ASMs in 28 years history. And it's the first time in Birmingham. So I hope you're going to enjoy the next 2 days of conference. And before I forget, we got a gala dinner tonight. If you haven't already booked the tickets, please go to the registration desk and buy the last few remaining tickets. And I will hand over to Imran now. Thank you.
Lovely. Thank you, Sajay. And welcome, everybody. It's great to see so many people join us today. As Sajay said, it's been a long time in the planning, a lot of hiccups along the way, but we're delighted that we've got 2 fantastic days ahead of us. Great program, great world-class speakers. It's been a lot of effort. Sajay and the LOC have really spent a lot of time planning and preparing this meeting. I think we've got a world-class program ahead of us over the next 2 days. DAS is not just about the scientific content, it's also about networking, it's also about making friends and future meetings as well. So we've got many meetings ahead of us, and many people do come back to the DAS ASMs. It's something that we're very proud of, and we love to maintain that. A couple of things. One is, as Sajay has already mentioned, please register for the gala dinner this evening if you haven't already. The spaces are limited, but there are a few available still. And also the trade stands. We've got a really nice exhibit area with lots of trade there, and they really heavily subsidise the price of the registrations for you guys. So please do visit the trade stand, do show some interest and speak to the trade exhibitors as well. Please enjoy yourself. We've got 2 fantastic days ahead of us, and really looking forward to the program. So I'd like to welcome our first speakers, and I hope you enjoy the rest of the conference. Thank you very much.
Yeah, before I forget, I know this is a welcome address, but I want to use one sentence to thank my colleagues in the organizing committee and also the DAS committee who have been very supportive throughout all these years. I don't think there will be a vote of thanks, so I'm just using this opportunity for that. Thank you.
Right, good morning. We're going to kick off with a fantastic NAP 7 presentation from Tim. I mean, I've got loads of notes about Tim, but you all know him, and you don't want me talking about him. You want to hear what he's got to say. This presentation is going to take 30 minutes. The session is 35, so we've got 5 minutes for questions at the end. There are 4 fixed mics, so if you just want to come down to the mics and ask your questions that way. All right, so without further ado, I'll hand over to Tim Cook.
Hello, Birmingham. Good, so we're about 6 minutes ahead of time already, so excellent. Pleased I've got extra time. So I'm holding slide. I'm Tim Cook, I'm an anaesthetist and intensivist from Bath, ageing, soon to be gone, and hopefully I've got some historical knowledge. But I've also got something that's up to date, so I'm going to talk about NAP 7. And I've thought quite hard about what to say. I'm going to talk about airway breathing, cardiac arrest. But I'm going to divide the talk essentially into two halves, and I am going to rattle through. I tend to go through things quite quickly, but I'm going to rattle through the first half, which is an introduction to NAP 7, and then focus on airway and breathing in the second half of the talk. So that's me on Twitter and the Twitters that you might want to, or X's that you might want to use, and if you want to email, that's it. Just leave those up in case you want those. Ask me any questions via that email. So this is a report at the heart of the matter, important findings of the 7th National Audit Project looking at perioperative cardiac arrest. I would encourage people to read it. There isn't a print copy of it. It's a bit of a lump. It's more than 500 pages long. Quite a lot of that is appendices, but we've been fabulously supported by Anesthesia, who are producing quite a few of the papers, quite a few of the chapters as papers. And so the full report is, as usual, free and downloadable. Just if you Google NAP 7 RCOA, it'll take you to the page, and you can either see you see the full report in the accompanying papers there. There's more papers to come, or you can scroll down and see the chapters. So as of 8 o'clock, there's a new paper out today, which is essentially the topic of my talk today. That's out now. You'll find it on Twitter with one of Mike Charlesworth's infographics. And we'll try and go beyond the infographic. Just put that back up in case anyone wants to scan the QR code. So as I say, as well on the NAP page, there's also each chapter. I hate to tell you there are 39 chapters, but I think as a minimum, anaesthetists should probably be reading the patient story. They should be reading the summary of key findings and the main recommendations. Like the NAPs, as usual, there are lots of recommendations, but we've tried to summarize the main recommendations into 20, none of which I'm going to talk about today. And then your specialty area chapters. They are actually bite-sized chapters, and I would encourage people to read them. So we started back in, I think, late 2018, so it's a sort of a 5-year project. Things were going well until about February, March 2020, when there was obviously an interruption. And the whole project changed at that point. So it changed to all virtual, having been previously all face-to-face in the room, all paper-based, and now all virtual. But essentially, the NAPs didn't change. So for those that don't know what the hell the NAPs are, they are effectively national inquiries, 1-year inquiries into the state of the nation regarding one particular sort of a complication of anaesthesia, perhaps involving critical care as well. And to be included, they need to be rare complications that are important to patients. Why study them if they're not important to patients? Important to anaesthetists because without anaesthetists engaging in the projects don't work. They need to be not studied by better methods and not already fully defined. And they usually run these 3 parts: baseline, activity, and case reporting. And they are, bar none, or par excellence, a collaboration of all UK anaesthetists, with about 70% of all UK anaesthetists involved in even one phase of it. Why did we choose NAP 7? I think this is from one of the slides from Fiona Oglesby's proposal back in 2018. People are scared of dying during anaesthesia, and although cardiac arrest is not equating to death during anaesthesia, it is, if only temporary, a form of death. So, NAP 7, perioperative cardiac arrest. Lots of people involved, lots of stakeholders. It's probably a broader topic than many of the previous NAPs, hence the size and also the size of the number of stakeholders involved, and we have to thank those people who were involved as stakeholders. This is the core panel, so we've got effectively 4 fellows, 3 official fellows, but de facto 4 fellows, and then Jazz on your right and me on the left, and this is all 2019. The years have been bad to us, but there you go. Inclusion criteria, essentially a period of cardiac arrest requiring or or near to cardiac arrest, requiring 5 chest compressions while under the care of an anaesthetist in the perioperative period. And as I say, those are the three processes. The baseline at the start of NAP7, the activity survey, the activity survey was in November 2021, and November 2021, and case reporting 2021 to 22. So the NAP7 inclusion period was essentially from when the anaesthetist first lays hand on the patient until 24 hours post-op. We're very aware that we probably didn't get most of the post-operative cardiac arrests, but we like to think and believe we probably got most of the in-theatre and recovery cardiac arrests, and a substantial number from post-operatively. And then in the activity survey, we looked at complications, well, we looked at cases, we looked at the where, the who, the what, the why, maybe not the why, but the what, and then we looked at the complications just in theatre, so the time periods slightly differ. Are they big studies? Yeah, they're big studies. So there are about 16,000 anaesthetists. Lots of them will be doing other things. They'll be doing intensive care, they'll be doing management, they'll be doing pain, they'll be doing other things. But we got responses to the baseline survey from 11,000 anaesthetists and anaesthesia associates. There will be a paper on anaesthesia associates in the time to come, which will be quite interesting. We got 881 cases. We had about 950 referred, of which we included 880. For those of you that don't know the review process, it involves a very in-depth review. So each case, which is completely anonymized but runs to probably about 300 or 400 data points, is subject to a formal and structured review process in which structured output from the review is done by a panel of three individuals. And once 3 to 4, sometimes 5, and once that output has been produced, so on a morning on a Zoom meeting we'd have maybe 3 or 4 panels of 4 or 5 people reviewing cases, and once over the morning they'd reviewed their 4 or 5 cases, in the afternoon we'd bring all the cases together and review all of them together. And that process, that double reviewing process, is deemed by many people who've been involved in these processes as to be as robust as anything they've been involved with. And then the activity survey was 26,000 cases, which, depending on how you slice it, comes down to 20,000 for most of the analyses. We also did phase 0, so we were delayed by the pandemic from launching from May 20 to May 2021. And during that phase, we did the ACT-TRACK, or Anesthesia and Critical Care COVID Tracking Survey, which will, I think, be discussed in the COVID inquiry and is probably the most robust study of how anesthesia and critical care were disrupted during particularly the December-January phase of the pandemic. And we looked at these three times. We looked at disruption of anesthesia, what was going on. We looked at how well hospitals were coping. So green means I can do elective surgery, yellow means I can't really, and red means I really can't do anything. And as you see over those 3 periods, this is December 2020 to January 21, overall hospital status, the vast majority of hospitals not being able to do elective surgery, the impact on that meaning that this is phase 3 emergency surgery, cancer operations, non-cancer operations, pediatrics. In some regions, pediatrics down to 12% of normal activity. The overall effect in December to January, you'll remember it well, less than half of normal surgical activity going on. And when you consider that most emergencies were going on, the amount of elective surgery was almost non-existent. But not enough time to talk about that. The activity survey, I'll give you some highlights from that. So 26,000 cases. We've separated obstetrics for reasons which I could explain later if necessary, but essentially we found that the age of patients, so we did the same survey in 2013 for NAP5, and then 10 years later, 10 years later, we've done it for NAP7. And you can see that there's a right shift of age. So it seems small, but we're anesthetizing older patients. Does that matter? Well, your actuarial risk of death increases 10%, not on your birthday, but for every year. Your risk of dying the following year is 10% higher than it was the year before. So over 3 years, sort of compound interest, that adds up to about 28, 30% increased mortality, just by dint of getting older. So we are operating on an older population, and the increasing aging of the population, the surgical population, is faster than the aging of the overall population. In terms of weight, some of you may have seen this already, so there's a 10% decrease in slim patients undergoing surgery, and they've been replaced by fatter patients. And the greatest increase has been in the most obese patients. I mean, we've only gone above 35 there, but not only is the extent of the proportion of patients who are obese increasing, but so is but the greatest increases are in the greatest. So it's not just the proportion of obesity, it's the extent of it as well. Comorbidity, so ASA, there's a little bit about reclassification of ASA, but probably not as much as people read into it. So ASA1 patients have dropped dramatically in that 10 years, ASA2 increased, but ASA3 a lot. And if we just look at the ASA4 or 5s, the numbers don't increase very much in absolute terms, but the proportion of patients who are ASA4, although it's only gone up 1%, it's about a 50% increase overall from what it was 10 years ago. So we're dealing with a much more comorbid, elderly, high-risk patient. And those have implications for everyday care, but also for anaesthesia. And these are some of the diseases. So if we look at someone approaching retirement, someone that should be 56 to 66, then hypertension, respiratory disease, probably mostly asthma and diabetes, not uncommon. They don't increase a lot as you age. Maybe those with those diseases don't always survive. But this degree of comorbidity here, rapid increase. And we've looked at complications as well. So in that same cohort of 26,000 patients, we looked at complications, and we chose those complications which could progress to a perioperative cardiac arrest. So those are severe complications. So for instance, we're talking about airway breathing. These are the complications that were included in the activity survey. And I think you'll agree that those are all quite significant complications that can, and certainly in the database, did lead on to perioperative cardiac arrest. They're not trivial. For instance, in cardiovascular, hypotension was only included if it involved starting or considering starting central vasopressors. And what's the rate of complications? Well, the headline is that it's 5.6%, 1 in 18 cases. Quite a lot under the care of physician anaesthetists. And in some subgroups, it's much higher. So in neonates, for instance, it's 17%. Some of the individual complications are tenfold higher in neonates than they are in others. In different settings, different complications have predominance. So more than a third of the complications are cardiovascular, but if you add airway and breathing together, they account for 40%, and obviously that's the focus of this talk. What are those complications in that 24,000 data set? Well, airway, the second most common, instance of almost 2%, almost 1 in 50. Laryngospasm, failure to establish the airway, and that means failure with a supraglottic airway face mask or intubation, and pulmonary aspiration. Ephone are very uncommon. And breathing, you can read them there. I won't go through them in detail. So here we have this is from Andy Kane's paper, complications, and we've got this sort of heat map. So the darker it is, so blue is benign, yellow is, as you become darker, it becomes less benign. This is elective cases, very low rate of complications, and then much higher rate of complications, particularly metabolic and cardiovascular in elective cases, in emergency cases. And using that, we can then get the risk, the frequency of complications of individual things. So this is the Royal College of Anaesthetists one-sheet information pack for what happens during anaesthesia, what are your risks. And we now have new information. The NAPs were originally set up to provide information to patients, and this is a central role. And we can decide which of those complications we ought to be telling everybody. Who should everybody get all this information about these sheets? We can see cardiac arrest, 1 in 3,000, severe hypoxemia, failed and laryngospasm are in the uncommon. They're not in the rare or very rare, but these are. And we can slice and dice it and work out who is most likely to get complications based on a univariate analysis. So not surprisingly, it's the extremes of age, increasing ASA, frailty, males more than females, etc., out of hours. But that needs more nuance, and we'll come to that. The registry, these 800, almost 900 cases, and we can explore those in all sorts of ways. But the big numbers are important. Roughly 1 in 3,000 patients die, at least temporarily, during their anaesthetic. And in some setting, it's significantly higher. So in terms of frailty and the old age, about 1 in 1,200. So 2.5 times as often, but in absolute terms, still not very high, but high enough. Post-Montgomery, arguably this information is important for every patient and probably should be titrated according to their particular circumstance. And then if we go into low-risk groups, so is that concerning? So remember, awareness, 1 in 15,000, anaphylaxis, 1 in 12,000, major airway complication in NAP4, 1 in 140,000, I think, leading to death. But this is 1 in 3,000, considerably higher. But if we look at these sort of low-risk groups, we can see that the frequency decreases, but also the survival rate increases. So the multiplying factor, the proportion that survive, it's about 1 in a quarter don't survive, but here it's less than a tenth that die. So it's quite reassuring for the young and fit. So in these graphs, the blue represents cases, and the purple represents activity survey. So anything that sticks out, these are what I call pandit graphs, because they came in NAP5. Anything that sticks out well above the purple is an excess for that. So age is a risk factor, young and extreme old age risk factor for perioperative cardiac arrest, as is increasing ASA, as is male sex, as is frailty. No great surprise. The NAPs, remember, just tell us what we do and the consequences of that. But their great advantage is they add numbers. We can then talk in numbers with some knowledge of what we do, and we can see the other factors that apply. If we look at different specialties, I think this is a really useful graphic. So this is the activity survey denominator and the proportion of the denominator, the proportion of the activity. So here we'll see obstetrics is about 13% of all activity, but accounts for only 3% of cardiac arrests. So it's green. It's a very low-risk specialty for cardiac arrest compared to cardiology, cardiac surgery, vascular, which are about 1% of activity, but account for almost 10% each of cardiac arrests. And then we have to dive down and see what their outcomes are, their risk factors, et cetera, et cetera. But it shows you where things sit. It shows you the sort of prevalence of cardiac arrest, and it shows you the degree of risk for it. Thank you, Richard Armstrong, for that, and much of his excellent work. Well, all of his excellent work, actually. Where do they happen? Well, only half of them happen in theatre. Probably more than 1 in 8 happen in critical care. And a significant proportion happen in cardiac cath labs. We don't do much anaesthesia in cardiac cath labs, but we often get called. Remember, if a cardiac arrest occurred before the anaesthetist was called to the cath lab, they wouldn't be included in NAP7. We're really good. The UK can be proud that senior anaesthetists are involved in most high-risk care. So about 92% of cases involved an anaesthetist at the start of the operation in a patient who subsequently had a cardiac arrest, and that was 75% even overnight, so that's after midnight. We can work out who was involved at the time of the cardiac arrest, so these are called upset charts, and that shows that consultants were involved in that proportion of cases, so it's at the time of the arrest, with senior anaesthetists involved in that proportion and juniors in there. And we can see who came to help. So we can slice and dice it looking like this. What were the causes? Oh, we all know this, isn't this obvious? Well, actually, when we asked in the baseline what were the most common causes, this was not the list that anaesthetists came up with. And anaphylaxis was much higher in the list than it truly is. So major hemorrhage, the majority, but only 20%, less than 20%, bradyarrhythmias and cardiac ischemia. But if you look at different specialties, and your eyes may be drawn here to ear, nose, and throat, or head and neck, what is the top cause of cardiac arrest in that setting, the primary cardiac cause, varies by specialty. And this allows us, this sort of detail as we dive down allows us to think about what we do and how we should prepare them and how we should manage cases differently. What was the cause of the patient? So the cause of the cardiac arrest. So mainly we're looking at the key causes of cardiac arrest. We looked at, was it the patient? Was it anesthesia? Was it surgery? Was it organisational factors, etc.? And for the vast majority of cases, it's the patient, sometimes the patient alone, but often in combination with other factors. So the patient about 70% of cases, anesthesia 40%, and the patient and surgery 35%. I thought that it would be surgery that would be more often represented, but actually it's us. And if you think about something like obstetrics, so epidurals for labour, the patients are almost all, so that's 150,000 cases, the patients are almost all fit and well. So if a patient has a cardiac arrest, it's certainly not surgery, it's certainly not the patient, it's almost always anaesthesia. So you can see that depending on the setting, whereas in cardiac surgery, the patient is very commonly a factor, and vascular surgery particularly. There's loads more data. I'm just skimming over the top of it. We spend a lot of time planning and training to defibrillate patients. When patients have cardiac arrests in a perioperative setting, they're almost all, not all, but the vast majority do not need shocking. About 20% don't need adrenaline, only 17% are defibrillated. And mostly action is quick and effective. There's this lovely graphic of the outcome of patients, but I'm not going to go through it in detail, but just to mention that most patients, so 75% of patients overall were resuscitated, more than 90% of ASA1 elective patients, for instance. And the outcomes moderate, so that's a period of extra time in ITU. 96% of patients went to ITU. But about 38% died, and a third of those cases were an inexorable process, so 2/3 weren't. Do we produce patients with really poor outcomes after resuscitating them? No. Of those patients who went home, 88% had a modified Rankin score of 0 to 3, which means that they were essentially able to be independent. What are the themes? Well, read the gloves. Those are the themes. Not enough time to go through it, I'm afraid. So, part 2 of the talk, airway, which is what we're here for. Headlines, airway, breathing, cardiac arrest. Number 1, it's a thing. Number 2, breathing. Number 3 and 4, small children and sick children. Whatever it is, 5, obesity. And then what can we learn about NAP? So this is a ridiculous, ludicrous comparison to draw. 15 years on, the population has changed completely different inclusion criteria. Only a fool would make the comparison. Here I am, that fool, to make that comparison. What have we seen since NAP4? Well, there have been quite a few of these sort of case series. Hans, when he did this lovely paper way back a few years ago, called it a mini NAP, and he looked at almost 3,000 patients and looked at all the sort of airway complications that they might have. And then there have been these various cases since then, of reasonable size. Well, our activity surveys 24,000 patients. If we look at Endlich's and Cumberworth's paper from Australia and Oxford, looking at, 12 hospitals, 4 hospitals, about 100,000 patients. Well, effectively, our registry is the same, but it's 2.7 million cases and 385 hospitals. So we've got quite a lot of information. The baseline survey is subsumed into one line to say that, particularly for pediatrics, there's a lack of preparation for resuscitation. Remembering that anybody almost, so only about 15% of anaesthetists call themselves pediatric anaesthetists, but about 85% are involved in pediatric anaesthesia care and may be called when on call to be involved in resuscitation. Remembering that 85% of UK hospitals don't have a PICU and therefore need to resuscitate children who may need to go to a PICU. It's a lack of care. How has our practice changed? So we compare NAP4 to NAP. Comparing NAP3 to NAP4 is useless, but comparing NAP4 to NAP7 has some value. So we see in this sort of rather Euconian slide that we have NAP4 and NAP7 here. So we were using, 38% of airways were managed with a tracheal tube in NAP4 and 56% with the supraglottic airway. Now that's reduced. Remembering this was just the tail end of the pandemic. This was November 2021, so people were still probably, their practice I suspect was influenced by the pandemic, but probably also influenced by the change in patient characteristics, the change in surgery that we do, more laparoscopic surgery, the change in the patient's obesity, etc. What about supraglottic airways? Hurrah! Hurrah! So we were using 90% first generation 10 years ago. We have now caught up with Australasia, for instance. We're now using 2/3 second generation supraglottics. Hooray, hooray, hooray. How do we change the airway by BMI? Well, we don't really change it until the BMI reaches about 30, and then we start to increase the proportion of tracheal tubes and decrease the proportion of supraglottic airways. But if we're using a supraglottic airway, how does that change? It doesn't really change. So if you're going to use a supraglottic airway, you're either a second generation user or a first generation user until the patient reaches about BMI of 40, and then possibly it changes, but not much. So anaesthetists are essentially either first or second generation SGA users. Come hell or high water. What about complications? So again, from the activity survey, so we've seen that heat map. But if you look at the heat map of airway complications, we've got this, you can look at the individual rates of complications by mode of anaesthesia, you can look at it by age, etc. Then it doesn't change much between elective and emergency. There isn't much change. I mean, this is sedation, and it's based on 3 patients, so it's not really very, or 3 complications, it's not very much. And the same for respiratory. What do we take from that? It doesn't really change much whether it's an elective or emergency. I think airway and breathing complications are a part and parcel of what we do in anaesthesia. And you might say it's reassuring, there's not much increase with emergencies. I say it's not reassuring, it can happen to us in any case at any time, particularly if you're anaesthetising neonates. So all these complications, airway and breathing, about 1 to 2% across the board, these young people. But you go to neonates, you've got 4.5% airway complications. These are major, significant airway complications. 1 in 6 respiratory complications. And remember that list of potential complications that might happen, that might lead to a cardiac arrest? Well, they all did lead to a cardiac arrest. And A and B cases accounted for 12% of all airway cases. So 1 in 8 cardiac arrests in the perioperative or the intraoperative and perioperative period are due to airway and breathing complications. We do need to get it right. Of those cases, the majority, 2/3, were airway and 1/3 were breathing. And of course, we always focus on airway. And actually, I focus on airway in this talk. This is a difficult airway society, after all. But the outcomes are actually the other way around. So of the breathing complications, their mortality was notably higher than the whole of the NAP7 cohort, and the airways were notably lower. We're good at managing airways, and we're good at getting ourselves out of trouble when airway complications occur. But breathing complications are more of a problem. And there's a kind of a hark back to NAP6, the whole, well, no, I won't go down that route. What about BMI? So again, we've got this Pandit plot. So we've got in this group of patients, in the middle BMIs, where everybody's slim and fit and healthy, and there's a sort of sunshine and light around them, nothing bad happens. So this is BMIs, isn't it? Yeah, BMIs. And then as you get to the larger BMIs, you've got this excess of cases relative to BMI. These numbers are too small to know what's happening, but essentially, they're just very small numbers. But essentially, obesity above BMI of 35 is a risk factor for these airway complications. No great surprise, but it is. And remember, anaesthetists often don't change their practice. So we've got, for instance, 20% of cases of airway and breathing cases were in BMI above 35 compared to. Remember that the whole cohort, because the BMI has increased, the whole cohort, the mean BMI is about 27%, so it's in the overweight range. And probably, as in NAP4, emergence and recovery as an issue. By age, very small, very high risk. And then we've got this sort of, I think it's probably due to the bulge of late middle age or of early middle age. And then, these sunny, shiny, slim people, no problems. Just to touch on neonates and infants, it's a topic all itself, and therefore, of course, there's a chapter about it in NAP7. But 1% of anaesthesia activity, 24% of airway and respiratory cases in the registry, particularly neonates, particularly cardiac surgery. Induction and post-operatively, particularly in intensive cares, are particularly high-risk periods. There's a little thing about ethnicity as well. There's a chapter on ethnicity, and there's some soft signals. I suspect this is wrapped up with neonates and infants as well. So there is a slight excess of Asian ethnicity and non-white ethnicity in airway and breathing cases compared to the whole cohort. But also there's an excess in the younger age groups as well. ENT, head and neck max facts. Also here somewhere wrote a lovely chapter on airway and NAP4, in head and neck and NAP4. Well, it accounts for 29% of our registry cases compared to 8% of activity, so to 2.5-fold overrepresented. That's down from NAP4, which was 40%. And the cases are less, I'd say, anxiety-creating than they used to be. What were the sort of events that happened? So again, every sort of event you can think happened. And they often happened together, and they mostly happened in cases without predicted difficult airways. Again, going to that heat map, it can happen to us at any time, and most airway complications aren't predicted. We have to be prepared. And I call these composite events. So you may have failed intubation with a can't intubate, can't oxygenate, and failed supraglottic airway placement altogether, or you may have this one that had 4 different things going on together. But this whole thing of composite error, if something fails, the other things are more likely to fail, particularly if you're heading towards cardiac arrest. These are some of the themes that are discussed in the topic. I'm not going to go through them in great detail, but there are echoes from NAP4, a significant number after extubation, a disproportionate number out of hours, but not managed by trainees by themselves, I would say. The potential value of a second anaesthetist, the anaesthetist, a cardiac arrest when someone was doing awake tracheal intubation, providing sedation and doing the airway. In difficult airways, is that good enough? Most care good, but when care was not good, it was almost always before the cardiac arrest. And we're not very good at debriefing if patients survive. I'm just going to now compare apples and pears, apples and tables maybe, and specific items from NAP4 and NAP7. So bottom left, you've got what happened in NAP4 and then what happened in NAP7. Here we have aspiration. So yes, the inclusion criteria are different, but it seemed there was less noise around aspiration. A smaller number of cases. Remembering half of these cases died, so would have had a cardiac arrest at some point. They were not misuse of supracardiac airways. They were not misuse of supracardiac airways in obese patients. They tended to be at the time of managing emergency laparotomies with slightly dodgy RSIs. There was one case with a second generation supracardiac airway. Half of them died. Unrecognized esophageal intubation, unacceptable. 6 cases. So in NAP4 there were 9 cases, but only 3 of them were during anesthesia. Most of them had a poor outcome. Here we had 6, 3 effectively reported in the registry, 1 identified in the registry though not reported, and 2 in the activity survey without cardiac arrest. Essentially, absence of capnography or failure to interpret capnography was a common theme. We've got to get on from this. We've got to do better. Is this acceptable in 2023? Was it acceptable in 2017 or 2011? No. Intubation, critically ill patient, difficult ventilation, hypoxia, and cardiac arrest. Capnography was not in use. After reintubation, the arrest was sorted out. Emergency phoner. Do we need a phoner database? Well, here we had 58 cases of 70, so 58 anesthesia cases in NAP4 and 70 in total. NAP7, different criteria. It wasn't all phoners, it was just those associated with cardiac arrest. Just 6 cases, 3 by ENT, 3 not ENT. Absolute echoes of NAP4 in those cases, but far fewer numbers, and 2/3 died. So we can compare apples and pears. We can compare the numbers, we can compare the proportions, and we can compare what happened. This isn't acceptable. We've got to do better. Recommendations. I'm not going to talk about recommendations because I think time has come. There are national recommendations therein, but they are very similar to NAP4 in many ways. They are about recognising neonates and infants as a problem, hospitals being properly organised to look after these patients at all times. And if you're involved in paediatric care, whether on call or other times, you need to read the critically ill child chapter, the paediatric chapter, the airway chapter. They interlink with each other. The fact that we emphasise that training and being up to date is important for all anaesthetists throughout their career. Organisations need to emphasise this, and they need to deliver it, and anaesthetists need to take personal responsibility for it. That includes front of neck airway, although it's a diminishing demand. There are more recommendations. I won't go through them. Thank you very much. That's the end.
That was brilliant, Tim. Thanks very much. So there are 4 fixed mics. If you want to, there, and here. And if you want to come down and ask questions. I'll just kick off with one to begin with, Tim. So you say that British anaesthetists are not taking BMI necessarily into the account. My deodorant is failing me for this one. So they're not taking BMI into account, and you specifically honed in on a BMI of 35, increased risk. Would you recommend BMI 35, perhaps particularly men, tube them?
I'm just presenting the data. How do I interpret it? So I think we compare NAP 4 to NAP 7, we can see there's a change in the population. We can see, very encouragingly, there's a massive increase in second-generation supracortical airways, which should, I would have thought, be safer. And the lack of cases of aspiration and the sorts of cases we saw in NAP 4 softly suggests that change in practice is increasing safety. But we do see that if you are somebody who uses first-generation devices, you use them almost at whatever BMI. So I think, firstly, I think that 65% probably should be 90% for second generations. And secondly, I think we have to pay some attention to increasing BMI. And it's not just about the risk of aspiration. It's also about the risk of not being able to ventilate somebody and not being able to deal with their airway in an effective manner. So do I think everybody who's got a BMI over 35 should be intubated? No, I don't. But I think managing them with a first-generation supraglottic airway is probably not great. Not all supraglottic airways perform equally. In fact, they perform very unequally. And I think in some ways it's unhelpful that we lump them all together. So some devices perform twice as well, which means that other devices perform half as well. And I think we need to be more canny about it. We shouldn't, for a long time I've said, we shouldn't just use the device that is handed to us. We should control the device that is handed to us.
Yep, we've got a question up there.
Thanks very much, Tim. Alistair Baxter from Edinburgh Sick Kids, and thanks very much for giving me both more work by children now coming more to my hospital because nobody wants to anaesthetise them, and also to try and make a subgroup for paediatrics in Difficult Airway Society. I thank you very much for putting my case very firmly forward, and the fact that we have one lecture today on paediatric airways, which is again a very interesting sub-issue. There is a suggestion, however, that gas induction is the classic case of way that we anaesthetise little children, and total intravenous anaesthesia was proven by the apricot/nectarine study to be a little bit better. Should we therefore be encouraging total intravenous anaesthesia? However, some of the suggested work in the NAP 7 suggested that total intravenous anaesthesia was associated with a higher risk of cardiac arrest. How do I balance these two issues?
Sorry, just say that last bit again, would you?
So, total intravenous anaesthesia is said to be by the nectarine and the
just a bit about the outcomes.
It's said to be better, but there was a suggestion in the NAP 7 that total intravenous anaesthesia was associated with a slightly higher increase in the number of people having cardiac arrest.
NAP 7?
Yeah.
Okay, I would have to reread that. I've read most of it several times, but I'd have to recheck that. I don't think, so there's quite a lot to unpack in what you've said. Pediatric airway, high risk, yeah, we knew that. The NAPs just tell us what we knew, but they tell us in numbers. And they tell us where our gaps are in terms of provision. We do have gaps of provision. So I think one of the things about pediatrics is, so pediatrics, small kids, pediatrics, sick kids, so of the deaths, well, the cardiac arrests and deaths in the critically ill, they were not generally small children, they were medium-sized children, but airway and composite airway failure was a very common theme in those relatively small number of cases. But you put together the baseline deficits, the activity survey complications, and the registry cases of complications, and we really do need to focus on provision of children. And any on-call anaesthetist can be called to look after sick children in the DGH, where 86% of hospitals don't have a PICU, and have to look after them while those very overworked retrieval teams work out when and if they can come. So we probably do need to up our game in terms of preparation. I'm not going to answer the TIVA question because I can't remember the data, but I don't remember it as a big signal. Indeed, I don't remember gas induction or intravenous induction being very big themes in NAP 7.
Excellent.
But I may be wrong, and I apologise if I've
Tim,
failed to remember our own data.
Brilliant. But I think we are now out of time, and Tim's around for both days, I think, so you can.
There you go. Someone's at the microphone.
Oh,
Better
right.
take it. It'd be rude
Hi.
not to.
So basically, it's not actually a question, but I know everything is research-based and evidence-based and things like that. But in pediatrics, it's coming from a mother whose child had a okay? And whatever the outcome, so it was a successful outcome, no problem, but severe PTSD to the mom and the child if you try gas induction. I know it's very dangerous, maybe, to do a IV, possibly, but she said, my child could not breathe, and then they were trying to force down a mask, and that trauma is with her for the rest of her life. So maybe it doesn't come up in numbers, but you might consider doing, I would consider.
Okay, I'll respond to that comment.
Yeah.
For those that didn't get the comment, I think the comment was around gas induction, particularly in a bleeding tonsil, and the distress and possibly sequelae that might cause family members watching that. The comment I would make is that NAPs, they are an amalgam of a lot of anecdote in some ways. They're national M&M. But what they do provide us with is information that we can use in a global way to communicate with patients better. They don't solve all, they don't create answers for every problem. Of course they don't, but they are intrinsically clinically based. They are based on things that happen to our patients in a year in anesthesia. And they do provide us with a wealth of information that we can use to better inform our patients and help them with shared decision making. And also help us improve our practice. I would recommend that you read as much of the project as you can stomach.
Tim, that was a fantastic curtain raiser to DAS 23. Thank you very much.
Just wait for our speakers to come up onto the stage. Would you guys like to take a seat? So my name is Abijoy Choklada. I'm the survey coordinator for DAS. I'd like to welcome you to the specialty topic session. This topic session will last for 75 minutes. We'll have about 15 minutes for questions at the end. It's an exciting session with 3 great speakers who will introduce in turn. And as you'll see, we're going to go, it's almost a line of life. We're going to start off with obstetrics, move on to some challenging pediatric cases, and then discuss the management of people living with obesity. As I said, 3 great speakers. First up is Professor Mary Mushambi. Professor Mushambi needs very little introduction. Is a longtime friend and supporter of DAS. She's a DAS professor, an ex-honorary secretary of DAS, and was in charge of the DAS OA Obstetric Airway Management Guidelines published in 2015. She's an FRCA examiner, was a lecturer in medical law and ethics, and has recently retired from clinical medicine. And it leads up simulation for the University of Leicester. If you live in Leicestershire and you look up, you may see a light aircraft piloted by Professor Mushambi, as she now holds a PPL as well. Professor Mushambi.
Thank you very much, and thank you, Sajay, and the organizing committee for inviting me today. It's great to be here. I'm really delighted. So I was asked to talk about obstetric airway management, and because I've retired from clinical practice, I struggled a little bit to decide what am I going to talk about. So anyway, in the end, I decided that I was going to just concentrate on 3 topics, and I chose these 3 topics. The first 2, checklist and peri-intubation oxygenation techniques, is because I'm passionate about this, and I really do hope that from now on, we're going to be using these as routine, and my next 20 minutes will be arguing in favor of this. And then the third topic is supraglottic airway devices after failed intubation. And the reason I chose this is because when we wrote the guidelines, this is an area where we didn't touch in detail, and we should have done it, and we didn't. So I'm hoping really just to cover that gap. Now, you'll notice that I haven't put these on my list. I didn't put Pro4 or video laryngoscopes, and the reason is we should be doing this now as routine, so no discussion there. Cricoid pressure, I didn't touch because I haven't got much time. This could take the whole lecture time, so I thought, no, I won't touch on that. Rock sucks debate. Again, we could address this at question time, really for the benefit of those who still think we should be using succinylmethonium. So let's move on to obstetric general anesthetic checklist. So why did I choose this? Well, my interest started in 1991 when I started learning to fly. And I was handed over this checklist book. And I was told that I had to use it religiously. And I had to use it correctly because it wasn't a tick box exercise. But what I realized when I was using it was that actually it's a fantastic teaching tool. Not only was I learning every time I was repeating it, but whoever was in the cockpit with me would also hear and learn what I was doing. So actually, it's a real benefit. But the other reason I brought this up is because it's very topical. Now, for those of you, hopefully you've all received your BJA this month, this article is in the BJA talking about computerized checklist, which is what the aviation industry have been doing for years, and they're trying to introduce it into anesthetics. So, when we did the guidelines, I was really pleased that we were able to put a checklist at the top where we work with the team. But I know that there will be obstetric anesthetists in the audience who are going to challenge me and say, do we need another checklist? What's the evidence? And can we use it in an emergency? Well, let me see. I'll spend the next few minutes convincing you. So, is there a need for it? Well, this comes out of the number of general anesthetics that we're doing on the labor ward. In a 6,000 delivery unit, I was lucky if I was giving 2 general anesthetics in a month. And therefore, it's very easy to forget those vital steps in the rapid sequence induction. And this was eloquently demonstrated in this quality improvement project, which was published in 2016. Where what they did is that they did a multidisciplinary simulation teaching session. And they used a checklist to check whether everybody was following the correct steps. And what they found was that in 90% of the simulation that they did, multiple steps were omitted. And therefore, they decided that actually a checklist is really good to optimize preparation and to help us focus on those crucial rapid sequence induction steps that we often forget. So, evidence, does it make a difference? And I've got 2 pieces of evidence to show you that it does make a difference. The first one comes out of Sheffield. And what happened is that in 2013, they noticed that their failed intubation rate was significantly above the nationally acceptable rate of 1 in 250. So they decided to introduce multidisciplinary teaching and use the checklist as a teaching tool. And thankfully, when they checked again that in 2015, that failed intubation rate had reduced remarkably. The second piece of evidence is from Edinburgh, and this has been published very recently in the European Journal of Anesthesia. And Alistair is one of the authors of this, so you can always ask him questions if you like. And this was a quality improvement project where they were trying to improve the use of video laryngoscopes, low-flow nasal oxygenation, and ramped position. And what they did again is they used checklists and multidisciplinary teaching tool. And what they did is they observed how often the video laryngoscope were used, how often apneic oxygenation and ramp position were used before and after. And look at the figures there, significant increase in the number of percentage use. But what I want to point out to you is this one here, which was the increase in the first-time success intubation rate, which went up from 93% up to 97%. So I hope I've convinced you that it does make an impact on the output. So this is the type of checklist that they used. And I'm not saying it's the best. Being one of the authors, I can criticize it. I think it could be improved. And perhaps what we need is a nationally validated checklist that we can then use nationally. However, the principles are the same. So what it is, the principle is that you do it during pre-oxygenation to save time. Your ODP reads it to you, and you as an anesthetist respond. And the kind of things you're checking are, have you prepared your patient? Have you checked your equipment and your drugs correctly? And have you prepared for difficulty? Now, I just want to digress here a little bit and look at this sentence here, which talks about reduce the noise level in theatre. Now, is this a problem? Well, it's been highlighted, and it was highlighted a long time ago by Jenkins in 2015, and then more recently at the Edinburgh Anaesthetic Festival, where there was this poster here. And what they did is they measured the noise level in theatres, obstetric theatres, and it was 90 decibels. Now, what does that mean in normal terms? Well, look at that. For some of you who either ride a motorbike or use a vacuum cleaner, the noise level in the obstetric theatre was louder than that. So perhaps we really do need to go back to aviation again and try and adopt this sterile flight deck rules, where we make it mandatory that we reduce or have no disturbances during critical phases of induction and extubation, which is similar to the aviation industry. Now, another question that some of you may challenge me is to say, can we use a checklist in an emergency? Well, again, for that, I'm sorry, I'm going to go back to aviation again. Now, you've all heard of the Hudson River plane crash, where they did use a checklist in that crisis. But I don't want to touch on this because you've all heard about this and you don't want to, it's boring. I'm going to bring in a new crash, which was Michigan Air Show just very recently. So this was a privately owned Russian-designed military fighter plane. And there were two crew members, so the flying pilot and the safety pilot. So when they were doing the display, they suddenly had really severe engine problems. So they went through the checklist and decided, the safety pilot decided, we need to eject. Unfortunately, firstly, the flying pilot objected because he owned the plane. Anyway, he was overruled by the safety pilot and they ejected. And literally a few seconds later, the plane crashed. The pilot survived with some minor injuries. Now, just to really make it feel real, I'm going to show you a short video just demonstrating the last moments of this flight. So those are the pilots ejecting, and then a few minutes later, you can see the plane crashing, and that was literally just a few moments later. So I hope that I've managed to convince you all that a checklist is a fantastic training tool. And it also can impact on output and patient safety. And if pilots can do the checklist in those crises, surely we can do it in the obstetric theatre. I'm now moving on to the next part of my talk, which is peri-intubation oxygenation during rapid sequencing in obstetrics. And why am I talking about this? Well, because we have this evidence that nearly 20% of our patients, pregnant patients, are desaturating to less than 90% during rapid sequence induction. And this is compared with 1.4% in the non-obstetric patients. So there's something we're doing wrong, and therefore we need to do something. We need to embrace this thing of multimodal peri-intubation oxygenation techniques. So what I'm going to do in the next few minutes is really try and convince you that we now have the evidence that we should be doing this routinely in obstetrics. So let's look at low-flow nasal oxygenation, which you all know about. You use these simple cannulas, which are very simple to use, but the added benefit is that actually it's very cheap. In fact, it's probably cost neutral because if you use these cannulas for induction, you can use them for extubation, for recovery as well. So you're basically cost neutral. But the question you might all ask me is, does it work? Does it provide safe apnea time? Well, sadly, in obstetrics, we don't have the evidence in real patients. But we have it in this, which was a computational modeling study, which was done in Nottingham. And this was done in physiologically matched pregnant women with a BMI between 24 and 50. And what they did is they compared safe apnea times using face mask and using low-flow oxygenation. And look at the safe apnea times. If your BMI is low, you've got nearly 12 minutes to intubate that patient, which is 7 minutes more than with a face mask. But, not surprisingly, as your BMI goes up, that benefit is not as great, but it's still there. You've nearly got 4 minutes to intubate that patient, which is 1 whole minute extra. I'm happy with that. Okay, let's go to high flow nasal oxygenation. And I'm going to start off there with pre-oxygenation first. Now, you've all heard of these 3 papers, and they've been quoted over and over again saying that high flow nasal oxygenation doesn't work for pre-oxygenation. Well, I'm going to be a little bit controversial here because I'm going to question and say, is this really correct? Having done research looking at pre-oxygenation using high flow nasal oxygenation, it's really difficult to measure accurately end-tidal oxygen levels. Fortunately, we now have evidence to support my challenge. And this is in the form of this paper, which was looking at peri-intubation oxygenation techniques, comparing high flow nasal oxygenation and face mask. And in these patients, they had arterial lines, so they were able to measure blood gases and look there at the PO2 in the high flow nasal oxygenation compared with face masks. I hope this is enough evidence to overrule those 3 papers and say high flow nasal oxygenation is absolutely fine for pre-oxygenation. Okay, so let's move on to safe apnea time. Do we have evidence? And again, this is really surprising because we actually have 3 papers that are in real patients. I'm only going to focus on these first 2 because these were randomized and these patients had arterial lines and therefore they were backed up by blood gases. So the top one, what they did is blood gases post-intubation and look at the PO2 between the 2 groups. The second group was blood gases after 3 minutes of apnea. And again, look at the difference. So I hope again you agree with me that collectively, these papers are showing that high flow nasal oxygenation as a peri-intubation oxygenation technique is superior to face mask pre-oxygenation. Now, obstetric anesthetists will come to me again and challenge and said, our patients are always obese. What happens with obese patients? Well, let's look at this. And for this, unfortunately, we don't have data in real patients, but we have in this computational modeling studies, where patients were studied physiologically match patients to a BMI of 50. And look at the safe apnea time comparing the 2 techniques. There's no doubt about it that the high flow nasal oxygenation outperforms the other 2 methods. Now, I want to quote this paper, which is a non-obstetric paper, because this is really a nice paper, and a lot of the big message from this is transferable to obstetrics. So this is a paper that's just been recently published in the BJA, and they were comparing high flow nasal oxygenation with face mask in patients with a BMI of greater than 45. And they looked at the proportions of patients whose saturations were above 92% at 18 minutes and comparing the 2 groups there. And the results were fascinating. Look at this. So nearly 90% of the patients with a BMI of greater than 45 had safe apnea times of 18 minutes. That's amazing. However, we need to be careful how we interpret this study because it's a unique study. And the reason it's unique is that this was done by experienced bariatric anesthetists. They had the patients sitting 45 degrees head up. They also checked the mask ventilation before they included the patient in the study, and if that patient they could not mask ventilate, the patient was excluded. They were also meticulous about maintaining a patent airway and the mouth closed. So yes, it's unique, but it's got a really important message, and the message is, with attention to detail, morbidly obese patients can have safe apnea times of 18 minutes. That's a really strong message. So, where are we with high flow nasal oxygenation in obstetrics? Just to summarize, well, I think it's good enough for pre-oxygenation now. We've got the evidence. The technique is important. That attention to detail, the position, patent airway, closed mouth, flow rates. And if we do that, we will have safe apnea time, and we might even be able to do it in morbid obese patients, you never know. But of course, we mustn't forget to take advantage of using a face mask with OptiFlow switch, because we can then check mask ventilation or use it as a rescue technique should you have any problems during the apneic phase. Now, one question I'm often asked is, should we use high-flow nasal oxygenation or should we use low-flow nasal oxygenation? Well, I think there's no easy answer here, but I think it's really dependent on two things: resources and comorbidities. Resources, low-flow nasal oxygenation is cheap, and perhaps that's what we should be using routinely in all patients. But when you have somebody who's got a higher risk of becoming hypoxic, such as high BMI, predicted difficult airway, or preeclampsia, then perhaps that's when we should be using the more expensive high-flow nasal oxygenation. It's just a suggestion. Now, moving on to the last part of my talk, supraglottic airway device after failed intubation. Now, why did I pick this? Well, let's imagine you've had a failed intubation. Your priority is to oxygenate that patient, and personally, I go for a second-generation supraglottic airway device, and hopefully it takes me to this pause moment where I've got to decide, do I proceed or do I wake the patient up? So we decide to proceed, and you've got that supraglottic airway device inside you. Question often rises is, what do we do with that supraglottic airway device? Well, the guidelines say, if it's working, leave it, because you don't want to traumatize that airway. And that's absolutely fine, and it still applies. However, there will be situations where you think you probably need to intubate through that supraglottic airway device. And this is the area that we didn't cover. When might that be, and how do you make that decision? Well, fortunately, this was answered by Wong and colleagues who published this paper in 2020. And they identified 4 factors to consider while you're making that decision: the type of supraglottic airway device, the technique, surgical factors, and maternal factors. So let's look at the second column, which tells you when you might consider intubating. So you'll have a second-generation supraglottic airway device, okay, but one that you can intubate through, so not a Supreme. And then you've got your appropriate equipment. You've got your Aintree, you've got your fiber optic scope, and you've got an anesthetist who's trained to do it safely. As far as surgical factors, you've got somebody with a predicted complex and long surgery, also a high risk of PPH, like a placenta previa. Patient with a high risk of aspiration, so somebody who's just eaten a meal before you take them to theater. And then patient with a high BMI, a bit like that. So that's the end of my talk. I hope I've managed to convince you all that obstetric checklists are a fantastic teaching tool, and we should really be considering using these before obstetric general anesthetics. Peri-intubation oxygenation techniques are not optional anymore. We should be doing it routinely, and multimodal intubation oxygenation techniques. 4 factors to consider whether you need to intubate through that supraglottic airway device after failed intubation. Thank you all very much, and I'm very happy to answer questions later on.
Thank you, Prof. My name is Sajid Kumar. I'm a consultant anaesthetist at University Hospital, Birmingham. We already have a pediatric theme emerging on the day. So we've got a fantastic speaker, Jimmy Montgomery from Birmingham Children's Hospital. We asked for his bio, and he said, it's very simple, mate. I'm just a consultant anaesthetist. So he's got 20 years of experience. I've got first-hand knowledge of him training myself and a lot of other people in Birmingham. Excellent clinician. He does cardiac as well as pediatric airway is his main area of interest. So his talk is going to be an interactive session. So he'll be using Slido. Please take the poll, and I'll hand over to Jimmy now. Thank you.
Great, thanks very much. Have we shown the Slido QR code yet, or do we need to show this Slido QR code? Possibly. Otherwise, it's going to be well, you're going to just have me talking. So. Oh, okay, great. Right. We can go back to the cases for discussion. Great, thanks. I am Jimmy. I'm one of the anaesthetists from Birmingham Children's. I'm sorry, I don't have any beautiful pictures of beautiful Birmingham. As I say, I'm one of the anaesthetists from Birmingham Children's. I've got 3 cases for you. I'll just quickly go through them, and then we can sort of go through interactive as well. The first case, that's quite a common case for us. It's a syndromic patient known to be difficult to intubate and has had several previous anaesthetics and successfully managed their airway and has been listed for an ear reconstruction. For those who don't know what an ear reconstruction is, it's a long operation, essentially. Here's other pictures of various patients with golden hearts. So back to the case, TIVA induction, old school in the sense that they checked for the ability to bag before they gave paralysis, and then unfortunately was unable to intubate. Became increasingly difficult. I don't know whether they used a second generation. I don't think we actually have second generation in our hospital, but anyway, the LMA did not prove to be effective, and they decided actually at that point to wake the patient up and gave Sugamadex. Unfortunately, I don't know how far they got with the Sugamadex, whether they actually got to spontaneous breathing, but the patients deteriorated. They couldn't maintain SATs. In fact, SATs were either high 70s or low 80s. So they decided to do front of neck, reparalyzed, and front of neck was obtained safely. As an aside, the registrar who did the scalpel bougie technique had actually just done a workshop about 2 weeks prior, so it's always worth doing workshops, I guess. The other thing is he now teaches our course, just a plug for our course, as it were. So you've now got a patient who's oxygenated, got a successful front of neck. What do you think you should do next? Can we have the first Slido slide then? Can we have the first Slido slide? Brilliant. So I'll give you about 30 seconds, see what you think. Okay, I think 200 is probably quite a good poll. I don't think there's a right answer to this. Whenever I ask this question about the majority, half of them will either say, let's carry on, and then half of them will actually say, let's wake the patient up. There's a minority who will say, well, you should do a formal tracheostomy. What they did in this case was that they did a nasal intubation, having a look at the airway as well. And actually it was relatively easy, apparently, and they managed to put the tube in. The airway wasn't that badly swollen or damaged. They also thought that actually, given the fact that the patient had been breathing previously, that actually they'd sort of discounted doing a formal tracheostomy. They stopped everything, and then they went and talked to the parents. They had a long chat, and then they decided to do a bilateral ear reconstruction. That luckily went well. The patient went back to ITU and was successfully extubated the following day. Can we have the second Slido one, please? So, obviously that's great and all the rest of it, but what do you do when the patient comes back again? Which, I mean, luckily for us, he was 14 at the time. This is some years ago, so he's in a different hospital now. But That's great. But what would you do if he came back and he was still sort of under 16, as it were? So I'll leave you another 20 seconds, see what you think. Okay, yeah, I think that's probably okay. So yes, I think given the fact that you lost the airway last time, I think actually it's probably worth entertaining the fact that actually maybe you could maybe intubate this patient awake, or if regional is appropriate, do regional. I actually think that it'd be actually quite difficult to do this asleep again. I don't know what technique you could use. I guess you could try and maintain spontaneous respiration, but under GA, that's quite difficult in an outsized patient. You obviously know that the LMA may not bail you out. So even if you do a general anesthetic, you're going to have to counsel the patient that there's a chance that A, you might have to wake him up, or secondly, you might end up with a second front of neck, as it were. Okay, back to the just normal presentation then. So we organize our surgical front of neck grab pack as such. There's one for needle cric, and there are various kind of age groups for surgical cricothyroidotomy, I should say. With sort of awake intubation, as it were, my rule of thumb is under 8 months or over 8 years. There's not much in the way of evidence out there. This one looking at sedation versus general anesthetic, the numbers are really small. The sedation group's 60 versus the general anesthetic, which is 500 odd. The thing to say about the sedation group was that actually a lot of them were teenagers. I think 40 to 50% were teenagers. And the second thing to say is that about a third of them had to be converted to GA in order to actually intubate. So if you're planning an awake in a child, yes, you can do it, but anticipate that potentially you might have to wake them up. I mean, not wake them up, but actually give them a GA, as it were. Or wake them up, I guess. Now would be a good time to sort of talk about paralysis and difficult airways. It's a kind of elephant in the room with regard to sort of pediatric anesthesia, because traditionally, we use gas inhalation and we maintain spontaneous respiration when we're dealing with difficult airways. And let's be fair, it's a tried, trusted, and it does work. But obviously, we've got various fruit-based snapshots of pediatric anesthesia, and they show really that actually we use a lot of muscle relaxants. We use a lot of muscle relaxants to intubate. We even use muscle relaxants to intubate difficult intubations. And there's a potential that actually using muscle relaxants, in all comers that is, reduces adverse events. But what about difficult airways and difficult airway series? This one is looking at muscle relaxation and face mask ventilation. And superficially, you would think that, yes, actually, muscle relaxants might actually be of benefit. However, like everything in anesthetics, everything is nuanced, as it were. If you look closely, the most frequent actual effect of muscle relaxants is actually no effect at all. As the airways get more difficult to manage, actually, there's not an insignificant number of patients that actually get worse with muscle relaxants. And actually, the biggest game changer was actually sticking an LMA in. Similarly, if you look at this one, that's looking at the frequency of adverse events in difficult airways, comparing spontaneous ventilation to controlled ventilation. And again, on first look, you'd think, well, controlled ventilation wins because there are less adverse events, almost half, as it were. But they've split the controlled ventilation into with and without muscle relaxants, and they have the same adverse event frequency, as it were. So depth of anesthesia as well is important when you're dealing with these patients. So like everything in medicine, it's going to be a combination of things that gets you out of trouble rather than relying on one thing or the other. But what about this? I think we could all agree that we probably ought to be paralyzing patients before doing front of neck. So I've got this case for you guys. So this is a 2-month-old, quite small, 2.7 kilos. It's not uncommon. They always turn up in the middle of the night, stridulous, and obviously working their way towards actually requiring intubation, CO2 going up, work of breathing, not so great. So gas induction, and then they had a quick look. I think it was with direct laryngoscopy, and they were unable to intubate despite the fact it was being a grade 1. Then your worst nightmare, as it were, became apneic. They couldn't bag. hypoxic arrest, CPR, adrenaline. I think 2 or 3 rounds of adrenaline. Decision to do front of neck, unfortunately, they used a needle crike, that failed. CPR resumed, and then miraculously the child started to breathe again. Improved saturations. ENT arrived, they decided to take the patient to theatre, they had a look, and then they proceeded to do a tracheostomy. So this is what they saw, which is essentially a laryngeal web, so they wouldn't be able to do any kind of tubing, as it were. Various points from this. The first one, which we'll talk about, is where you do these patients. Obviously, you might have your own thoughts about this. I mentioned tracheostomy because actually that is potentially quite difficult. The ENT surgeon who I work with, he's got 20 years experience, and he sort of calmly says, I can do one in under 2 minutes, but that's 20 years experience. 2 minutes is quite a long time. Failure to thrive, that's a bad sign or good sign, depending on how you want to put it. That would suggest that there is pathology. I'm not saying this case means that you shouldn't paralyze the front and neck, it's just food for thought. I would say, though, this is one for, VL users, as it were. If they used a VL, they might have made the diagnosis early, as it were. They certainly would have seen that, and that would have been prevented multiple attempts to intubate. And obviously, this is a different larynx, but you can see actually this is someone having had multiple attempts at having to intubate, and you can cause a lot of trauma. So back to this, as it were. So where do you think we should be intubating these patients? If we have the last Slido, as it were. Okay, I think we can see who we've got here. I mean, naturally, as anaesthetists, we prefer theatres, as it were. And that's fair enough. That's where you're at most home and all the rest of it. I would say, though, it's all about context. So imagine if you're on ITU and all your team are from intensive care, then you take them up to theatres. They will not know where anything is. So that's the first thing. The other thing is if your LMA is particularly precarious, as it were, or your airway is very precarious and it's actually basically not really doing a lot, we've all made that mistake, with anything, cardiovascularly or not, of just saying, all right, let's go to theatres, and then in the lift decided actually that wasn't such a great idea. So although theatres, for us, would be the sort of ideal place to do these patients, it is all about context. I'll just go back to main slide again, main presentation. So the final one, it's very quick. This is a neonate, postnatal diagnosis of a mediastinal tumour, and obviously particularly symptomatic as he's now been nurse prone and on airvo, as it were. And the surgical plan is to resect it via stenotomy. It doesn't look better, bigger. And you can see from the CT scans that actually it's involving a lot of serious clockwork, and it's compressing at the level of the carina and beyond, as it were. One thing to remember about scans is that they're not dynamic, so there's obviously air going to the left side, so even though the left main bronchus looks like it's totally collapsed, it must still be open, as it were. It doesn't look any better in that view either. So here you go, you've got a significantly symptomatic patient with a mediastinal mass. Obviously, there are quite a few series now talking about how you would actually anesthetize the patient. Probably the best thing to do is to avoid it and take a holiday. But if you did have to do it, there are various things that, well, the two main pointers for anesthesia are if you've got compression of the tracheal bronchus or significant compression of the tracheal bronchus, they are more likely to decompensate after you give them an anesthetic. And the second thing is it always seems to sort of precede giving the muscle relaxants when you get that decompensation. Like I say, these are sort of questions you might ask other than have you still got more holiday left? I'll just leave them up there for a second. So they did an MDT. I'm not actually even sure they invited an anaesthetist, but That's our hospital for you. Anyway, they discussed various options as to what they could do if the patient were to decompensate. So they talked about femoral ECMO. I'm not an expert on ECMO, but they decided that femoral ECMO is actually quite difficult to do in a baby, and they sort of discounted it. And then they decided actually, if there's a problem, we'll just open the chest and lift the tumor and everything will be fine, or we'll just directly cannulate and do ECMO that way. I put plan and reality up there because actually they're so far apart as to be a bit of a laugh, as it were. When they opened the chest, they sort of manipulated the tumor as you would do. And actually, it didn't make any difference at all. The anesthetic team sort of reported sort of kind of pressures in the 60s or 70s sometimes just to get any kind of oxygen into the patient. And then the cardiac surgeon said, actually, we wouldn't have been able to cannulate anything, either atrium or any of the vessels as well. So we wouldn't have been able to put the patient on ECMO. So, you know, like we say, we're anaesthetists. We always like plans, but sometimes it doesn't work out. This kind of reminds me of that quote of Mike Tyson's, you know, the one that says, you know, everyone has a plan until they're smacked in the mouth. This kind of is similar. I know that's a riff on No Plan Survives First Contact, but I think we all prefer Mike Tyson's version. Anyway, that's the end of my talk. Any questions?
Thank you, Jimmy. To close the session, we have Dr. Becky Black. Dr. Black is a consultant anaesthetist at University College London Hospital. She's the Vice President of SOBER, the Society of Bariatric Anaesthesia, and is passionate about the safety of people living with obesity. And Dr. Black's going to talk to us about airway management in bariatric surgery.
Good morning, my name is Becky, and in the next 17 and a half minutes, I'm hoping to cover some London-wide safety data, some national guidelines, do a bit of myth busting, and mainly give you some top practical tips of how to manage patients with obesity. Firstly, whether or not you anaesthetize for metabolic surgery, the reality is that obesity has become a pandemic. Sorry if that's a triggering word. Rates of obesity are only increasing. And now there are more people aged 18 to 40 with type 2 diabetes than type 1. 3/4 of adults over the age of 45 have a BMI greater than 25, and perhaps the most confronting data is from our pediatric population, where 2 in every 10 10-year-olds are obese, and 4 in every 10 4-year-olds, are obese. And the reality is that these obese children become obese adults, and the rates of obesity are higher in low socioeconomic groups, So if you cast your mind back to 2011, perhaps a happier time, when NAT4 came out, the word obese featured 274 times in the NAT4 report. And there was this statement that really spoke to me, and it said that too often obesity was not identified as a risk factor for airway difficulty, and that modifications to the anesthetic were not made. This idea that obese patients are different, their physiology is different, and they need to have a different anesthetic. It went on to make 12 obesity-related recommendations. Then a few years later, the association and SOBER put out this guideline, perioperative management of the obese surgical patient, which is very comprehensive and amongst other things talked about equipment that can help manage patients with obesity. And then SOBER, because it's a fantastic society, understands that you might not have time to read however long excellent guidelines, and they came up with a SOBER single sheet, which is just really pragmatic advice about how to manage patients with obesity. And so it got me thinking, is this a problem that was identified, appropriate and excellent guidance disseminated in many different forms? Is it a problem that was just sorted? So a few years ago, I ran BIGGER, which stands for Bariatric Issues in General Anesthesia Relating to Airway, which was a prospective observational study looking at elective surgery taking place in London. It ran in 39 hospitals and collected data on almost 2,000 patients, which was 91% of all the eligible patients. So it probably is a true reflection of what was happening in London during that week. And BIGGER aimed to answer 3 questions. 1, what proportion of elective surgery was being carried out on patients with obesity? 2, were modifications actually being made to their anesthetic, and was the equipment available to do so? And 3, perhaps the most important, was this leading to a reduction in harm? What were the modifications actually leading to a reduction in airway complications? This was published a few years ago in Anesthesia. And so what did BIGGER find? We found that 32% of the elected surgical population were obese. And this was an overrepresentation according to population data at that time, and I think that makes sense with the comorbid nature of obesity, high rates of cardiovascular problems, cancer, joint issues, gynecological problems. We also found that 32% of the elective surgical population were overweight. So the majority of patients that we saw that week had a BMI of greater than 25. We found that obese patients were significantly more likely to have complications compared to patients without obesity. As BMI increased, so did the rate of complications. So in class 3 obesity, which is a BMI of greater than 40, the complication rate was 21%. 1 in 5 patients coming for elective surgery had an airway complication, and I think that that is unacceptably high. Now, 4 introduced this concept that the complication can happen at the end of surgery, and true enough, with BMI of greater than 40, the majority of the complications happened at extubation or in recovery. In terms of what complications we're talking about, we used the exact complication list that was in the NAP4 report. This is a busy slide, but I'll just highlight a couple of things. First is the light purple, the most commonly occurring complication, which is a desaturation of less than 90%. These patients desaturate. I'd also like to highlight the dark purple, or lack of it, which is the rate of difficult intubation. In fact, in the study period, there were no reported difficult intubations with patients with a BMI of greater than 40. And this comes on to my first myth busting, that obesity is not associated with difficult intubation. It's not just BIGGER that's found this. There's numerous studies out there saying the same thing. And I think that sometimes we get a bit distracted at trying to modify our anesthetic for a difficult intubation, and we don't concentrate on what the most likely complication is to happen, which is that the patient is going to desaturate. And just thinking about why they desaturate, obesity affects all aspects of respiratory physiology, and this can be divided into mechanical effects and biochemical effects. There's more adipose tissue. There's more adipose tissue in the upper airway that can lead to upper airway collapse. There's more adipose tissue on the chest wall, and the weight of that causes decreased lung compliance and VQ mismatch. Biochemically, these patients have an increased oxygen consumption, and because of increased alveolar hypoventilation, there's raised CO2, and chronic hypercarbia is incredibly bad for you. The increased adipose tissue in the upper airway can lead to really difficult bag mask ventilation. That's undeniable. And they can have upper airway collapse. And of course, this can be without a formal diagnosis of obstructive sleep apnea. The most common measurable difference in patients with obesity is a decrease in the functional residual capacity. And this is more decreased as BMI increases. And overall, this leads to a decreased reserve in patients with obesity. Then at the same time, these patients have an increased work of breathing, an increased basal metabolic rate, and therefore an increased oxygen demand. And this is the classical mismatch between supply and demand. So when these patients become apneic, time is against you. It's actually illegal to do a talk about bariatric anesthesia without showing this graph. This is the time taken to desaturate after being fully pre-oxygenated, and no one desaturates faster than a patient with obesity. And when the sats go down, they can be extremely difficult to bring back up again. So it's undeniable that patients with obesity are at higher risk of problems during their anesthetic. They're at higher risk of airway complications, but they're overrepresented in all the NAP studies, higher risk of anaphylaxis, awareness, and now cardiac arrest. So do we tell our patients that they're at higher risk of these complications? SOBER asked the membership to see whether they routinely consented for obesity-related complications, and the majority of people said that they didn't. They felt embarrassed. They felt that obesity isn't accepted as a medical condition in the same way as heart disease or COPD. And so we listened, and together with our patient advocates, we created the consent guideline, which talks about how and what to talk about with our patients. The language we use really matters. We need to use patient-first language, patient with obesity. We don't say COPD patient, we say patient with COPD. We need to be mindful of our own preconceptions. We need to use neutral terms. The term morbid obesity is now no longer appropriate. Now I'm going to talk about some practicalities about anesthetizing patients with obesity. These are all featured on the SOBER single sheet guideline. I'm going to cover some induction strategies and talk about extubation. First of all, I've banged on and on about patients desaturating, so it makes sense to me to anesthetize these patients where they're going to have their operation, to reduce time off oxygen and off positive pressure. And this means in the operating theatre. This can also reduce the need for manual handling and can reduce the chance of pressure-related injuries because the patient self-positions on the operating table. It is important to note that not all tables are made equal. And I highly encourage you to get to know your equipment, particularly in the emergency operating theatre, because of just how life is. You will be required to do a laparotomy at 3 a.m. on someone who is 180 kilos, and you don't want to use your bandwidth working out whether the table will take them. It has to be said that lots of the weight limits assume a neutral position for the table, and if you are going to go to extremes, probably don't go up to the maximum weight. Most tables will take a patient up to 130 kilos, but after that inflection point, it's definitely important to know your exact equipment. If you have access to a hover mattress, they can be incredibly helpful. Although you're going to anesthetize your patient in the operating theatre, they still have to be maneuvered onto their bariatric bed at the end of the procedure. The idea is that you put the patient on top of the hover mattress before induction, and at the end you slide them across very easily. Definitely ensure that the hover mattress is fully inflated, and make sure that the mattress that you're transferring them onto is also fully inflated. I've learned that the hard way. And then you take the patient to recovery on the hover, and they self-position when they're awake, and it's safe to do so. They're usually multi-use items, and everyone gets very upset if you accidentally throw them away. In terms of remembering one thing from this presentation, it's definitely this: do not underestimate the power of the ramped position. Just the simple displacement of the adipose tissue massively improves the lung mechanics. Patients should be ramped for pre-oxygenation, ramped for intubation, if it's possible, ramped for the procedure, and if not ramped, but they should be sat fully bolt upright for extubation. You can do it with fancy pillows, you can do it with the operating table, but what you're trying to do is to get the patient from this to this, getting the level of the tragus level with the sternal notch. After you've maneuvered your patient into the ramp position, sometimes it can be difficult to reach their airway, and the answer is not to unramp them, but to maneuver yourself so you can reach them. And sometimes the most useful piece of equipment in the bariatric operating theatre is the step. The patients clearly need to be pre-oxygenated, and pre-oxygenation is a talk in of itself. Most bariatric anaesthetists use a face mask with PEEP, but more and more I'm using high-flow nasal oxygen, especially the newer devices which allow per-oxygenation. So they're pre-oxygenated, they're ramped, you're ready to go, you need to give them some drugs. How much are you going to give them? So SOBER has released a drug dosing app. It's free, it's available on iOS. We are developing an Android app. If you register on our website, we'll let you know when it's ready. And it covers pretty much anything that you're likely to give during an anesthetic. So after they're asleep, You need to ventilate them. I pop a Gadel in straight away, immediate two-handed ventilation while I wait for my paralysis to work. My next top tip is apparently controversial in some circles, but pretty standard in bariatric practice, which is to pop an LMA in whilst you're waiting for the neuromuscular blocker to work. This gives your hand a rest and allows adequate ventilation whilst you're, for those 2-3 minutes. Then for intubation, I recommend using a video laryngoscope as first line for plan A. This is not because I think they're going to be a difficult intubation, but because time is against you. You want that tube in as quick as possible, and I think that's with a video laryngoscope. Also, of course, if they're an unexpected difficult airway, what you're going to ask for is a video laryngoscope, so it makes sense for that to be the plan A. At the end of the operation, these patients need to be fully awake, fully sat up, fully reversed. They tolerate spontaneous ventilation really badly, especially in the supine position, and so I tend to wait until they're sat up before flicking them over onto pressure support. If I've used high-flow nasal oxygen at the beginning, it makes sense to use it at the end, and they can go to recovery with that happily. I'm very aware that the interventions that I'm describing are not fancy or new. They can be done by pretty much anyone, anywhere. This is a matter of doing the simple things well. And I looked through the bigger data and audited against adherence to the SOBER single sheet, and I found that these things were not being done, and when they weren't done, it was associated with higher risk of complications. So my standard approach when anesthetizing patients with obesity would be to anesthetize in theatre, on the hover mattress, in the ramp position. I pre-oxygenate with a tight-fitting face mask, 5 centimeters of water of PEEP, induce using drugs according to the SOBER app, a Gadel straight away, two-handed ventilation, and I'm not shy about putting in an eye gel. I intubate them using a glide scope. So in summary, consent is important, what we say and how we say it. Ramp your patients, pre-oxygenate, download the SOBER app, assess the airway, plan for failure, and definitely do take extubation seriously. Do come join us at SOBER. This is for the president, Andy McKechnie. We're a friendly bunch, and if you're not conferenced out, it's our Winter Scientific Meeting 1 week from today in London. I've been told there's 5 tickets left, and one of them's yours.
Thank you, and I think we're running 5 minutes ahead as well, so Sajay, that's for you. Are there any questions from the floor? While we're waiting, I'll kick us up. First question for Mary, please. It's really interesting listening to your talk, and specifically the checklist bit. I suppose the question for you is, it's very well having them, and from my point of view, it's a no-brainer, but how do we train colleagues to use them properly? And perhaps more difficultly, how do we change the culture so they are used in the first place?
I think actually Alistair's study really answers your question. I think you've got to start with the training, multidisciplinary training. So I know we don't do it often, and it's something that I think has been recommended over and over again, that's what we should be taking time to do it. To do multidisciplinary training, use the checklist as part of the ticking that we're doing the right thing and introduce it that way. The other thing is, all you need is enthusiastic anesthetists to start using it clinically, and you find that theatres will start learning and feel it's part and parcel of induction at elective cesarean section. And then it's a bit like when I introduced high-flow nasal oxygenation, I started with the elective cesarean section, and then eventually it rolls over onto emergencies. The other thing about checklists is that I personally feel, I showed you the one that we put together. I think it's not ideal yet. I think there's some modification to try and reduce it. I ran that through simulation, and it takes 2 minutes and 40 seconds to run through, and I think I just need to reduce that a little bit more, and perhaps have a different one for an emergency, for the real category 1 cesarean section, where you might want to have a slightly different one.
Thank you. There's a colleague with a question.
Thank you very much. Are you able to hear me? Yeah. Dr. Radhakrishna from Commentary. Thank you for 3 excellent presentations. Wonderful morning session. My question is regarding bariatric anesthesia to Becky. Very good presentation. Thank you very much. I have great interest in obesity, anesthesia for the obese, not particularly because the question is we all are doing morbidly obese patients more and more now. There was a publication, the European Society of Anesthesia, way back in 2014-15, I think, regarding how much of inspired oxygen we should use. And I know there was suggestion that we should use 80% or 0.8, as they said, to leave some nitrogen in. Now, some people, I mean, that was advocated way back. Some people follow that diligently. I don't know what you think about it. My own way of managing patients with morbid obesity, I feel that in morbid obesity, the problem is one of sustained oxygenation. That's what I often say. It is not so much as difficult intubation as sustained oxygenation. And I like to recruit the alveoli by using something like an eye gel instead of a mask ventilation, paralyze the patient, ventilate them on eye gel, then do the intubation myself. That's my practice. I would like to know what you think about that.
Thank you. Yeah, I totally agree, and I routinely do pop an eye gel in for pre-oxygenation, not for pre-oxygenation, after induction, waiting for the neuromuscular blocker to work. I only said it was controversial because once I presented that before in a similar audience, and I was told that if I think that bag mask ventilation is going to be difficult, why aren't I doing awake tracheal intubation? And my argument is I'm really not worried about a difficult intubation. These patients are difficult to hand mask ventilate, and so this is a neat solution, I think, for that.
So just to repeat the comments for people who may not have heard, I think the speaker was asking a question or making comment on how to manage pediatric patients who are critically unwell in quite austere environments, which we may find ourselves in some of more peripheral district general hospitals that don't have necessarily the kit experience or critical care cover. I suppose to kind of turn that into a question for Jimmy, do you have any pragmatic thoughts or ideas or advice that we can give to colleagues working in such areas and what they can do just to keep going until help arrives?
Thank you. That's quite a difficult question. Obviously, my heart goes out to you guys because obviously I work in a tertiary centre where, well, I wouldn't say we're flush with equipment, but we have essentially paediatric equipment, as it were. Judging by, I did the workshop yesterday, and judging by the number of consultants who work in places where they don't have pediatric fibre optics or anything else, but are still admitting pediatric patients to their ED, there's probably a significant number of you out there who don't actually have the equipment. And that obviously is a worry. I don't have the data, but certainly from the numbers of people saying that didn't have anything pediatric in their hospital, that would be a bit of a worry for yourselves, as it were. And certainly, I mean, I guess I don't know whether DAS is doing any audits on that, but it might be worth looking into in order to try and push for more hospitals to be, if you've got the data, you'll be able to push for more hospitals to actually purchase it, as it were. With regards to kind of intubating and stuff like that, I guess, as Tim said, it probably is down to the department and also individually as anaesthetists to keep a bridge of current developments, as it were. The unfortunate thing is that the horses and cavalry that arrive are essentially paediatricians. So even if you are waiting for your retrieval service to arrive, the likelihood is that it will be a paediatrician. And the likelihood is that you've probably got more airway experience than the retrieval team. And it's likely that they'll ask you to help with the intubation anyway. So I guess I think it's still in the college sort of kind of guidelines that suggest that you actually have to still, if you're admitting children, you still have to be able to resuscitate them and help with the retrieval service as well. So it's probably in your best interest to gear yourself up, as it were, but also have leads, make sure you are au fait with the current guidelines, as it were. There are hundreds of tips. I could go on for ages about tips. With regard to front and neck access, yeah, that's kind of controversial still, well, obviously in pediatrics, because basically there is no scientific backing, as it were, and obviously that makes it difficult to get any consensus. Obviously, the DAS guidelines still state, they're relatively old, but they still state that if you haven't got an ENT surgeon, and obviously that's the first protocol, but lots of places don't have ENT surgeons. We don't have an ENT surgeon sort of standing by ready with a scalpel. They have to come in from somewhere else, as it were, or from home, I should say. So if you're in that situation, then the DAS guidelines essentially suggest that you should do a needle crike as your first line. Needle crikes are, well, needle crikes are difficult, and obviously in adults it's been superseded by the surgical cricothyrotomy because actually it's better. It makes more sense. And needle crikes as such, the whole actual technique I think is quite difficult. Not only do you have to stick the needle in, and I think in infants, or neonates, I think the trachea actually compresses like it does with a vein when you're sticking the needle in. So there's a chance you might actually go through to the posterior wall, as it were. So that's just sticking the needle in. Even if you stick the needle in and you're in, then I always forget where you put the throughway tap in the actual sort of kind of configuration, as it were. And you're also giving quite high flows and therefore high pressures. So if you saw that the second case, even if they were successful in putting that needle crike in, because that kid couldn't expire, the chances are that you'd have inflated the lungs, caused barotrauma, and they probably would have had a tension as well. So it's not without its problems. So in a sense, I'm kind of edging towards suggesting you use a surgical crike, as it were. I don't have any evidence that that's better than a needle crike, but given how the adults are going, and how a needle crike is actually quite difficult, I think actually that's probably the way I'm going. I mean, I can say that and all the rest of it, but actually doing it is something totally different. As I say, if you saw the slide with the packs, we have different age groups for surgical crikes. The one thing we do include is an artery clip. Now, I don't have any evidence for this, but obviously when you put your first incision into the membrane, we then have to twist and then put the bougie in. The act of twisting may mean that you push the actual scalpel through the posterior wall. So what we've suggested, and we do on T-trolley sort of stuff, is we make the incision, take it out, put the, sort of like a chest drain, as it were, put the artery forceps or artery clip in, open out the hole, and then put the bougie or the Cook's exchange catheter or whatever we want to use in. And that's what we suggest, although, like I say, there is no evidence. My heart goes out for you, for all those guys out there in DGHs who haven't got any pediatric equipment. I can only say you've just got to push to get some.
Thank you.
Thank you. So a final question for Becky. You talked about discussions with patients and consenting patients appropriately for anaesthesia, and as you alluded to in your talk, some people find that difficult, possibly for a risk of offence. I see SOBER have a guide on how to have these conversations, but as a practicing clinician, what works for you?
No, absolutely. They can be awkward conversations. There's some really nice patient information leaflets. They're on the SOBER website. There's one we made in combination with the Royal College. There's also another one for obstetric patients. And so if you're seeing patients in pre-assessment or on the day of surgery, I find it much more useful to get the information leaflet out and go through it together. So perhaps if it's maybe a potentially insulting statement, it's something that the piece of paper is saying rather than what you're saying. The consent guidelines are really good about sort of what things to actually talk about. There clearly is no point in telling a patient on the morning of surgery it would be better if they lost weight. You're definitely going to have a communication and trust breakdown with the patient, although it may be true, it's clearly not going to happen. And I don't think it's the anaesthetist's role to tell people to lose weight. But yeah, there's some really nice patient information leaflets.
Thank you. So, there's a question just there. So there should be a microphone that we can get to. Just there's a mobile mic there.
Hi, this is a message for Jimmy, a question for Jimmy. How did you guess that kid with the mediastinal mass who was prone at the beginning? And did you use muscle relaxant? And